From Diamond Pharmacy Services, this is PodcastRx. On this episode, we welcome back Optics clinical pharmacist Christopher Bender to talk about the rising popularity of GLP-1 agonists, semaglutide in particular. We talk about these drugs' profound impact on diabetes and weight loss management, and how drugs like Ozempic have become in demand among celebrities and social media influencers. Of course, we also cover the basics, how they work, safety concerns, prescribing guidelines, and much more. And along the way, we also uncover a surprising connection to Gila monster venom. I'm Adam Campbell, and welcome to PodcastRx. Chris Bender, welcome back to PodcastRx. How's everything going for you these days?
Well, Adam, thanks again for having me. As always, things are going very well. Since the last time you and I spoke, my wife and I actually introduced our first child, so things couldn't be any better. I'm caffeinated and ready to roll for today's discussion.
Well, again, let me offer my sincerest congratulations to you and your wife. Amazing, and welcome to the world of parenthood, man.
Thanks, man. Feels good.
And also good to have you caffeinated, because we got a really good discussion coming up here. It was a great idea of yours, and I'm really excited to get into it here. So, Chris, I wanted to talk to you about a group of medications that's getting a fair amount of attention in the media lately. And that's the GLP-1 agonists. Listeners might know them better by their brand names, Ozempic, Wegovy, to name just a few of them. These medications, while initially developed for diabetes patients to manage their glucose, also made patients want to eat less, which in turn led to weight loss. And we're not talking a couple pounds, we're talking levels on par with bariatric surgery. So while Ozempic, or semaglutide, was FDA approved for glucose reduction, naturally there was interest in using it for off-label weight loss purposes. In 2021, a higher dose version of semaglutide called Wegovy was approved specifically for weight loss. And there's other medications in this space, which we'll get into, like tirzepatide and liraglutide, with similar functions. Of course, obesity is one of the most prominent physical societal ailments of our time. A seemingly routine weight loss medication to fight obesity could lead to profound savings in both health outcomes and money for a profoundly strained healthcare system. So these GLP agonists offer incredible promise that previous weight loss medications perhaps did not. And while we've seen highly touted weight loss medications flame out in the past over safety concerns, think fen, this new generation of drugs seems to be working relatively safely for now. One of the bigger concerns over GLP agonists at the moment isn't about side effects, though there are plenty. It's about access to them. The popularity of these drugs, Ozempic in particular among TikTok influencers and celebrities, has driven up demand, and that's been blamed for shortages. Combine that with supply chain issues and also with insurers who balk at covering these expensive drugs, and you have a substantial amount of people who've had trouble finding them or affording them. So Chris, given all these subplots, if you will, I wanted to get your pharmacist perspective on these drugs, from the 101 facts on them to what they represent for diabetes and weight loss moving forward, availability, social cachet, and everything in between. So let's just start with some basic pharmacology, Chris. Can you tell us what the available GLP-1 agonists are, how they work, and what makes them so effective for diabetes management and weight loss?
Well, first off, Adam, really fantastic introduction.
Thank you.
I really think that you set the stage for what I feel, obviously, is a pretty exciting topic. So the GLP-1 agonists, they're a class of medications that were originally approved for diabetes and still are. And I should note that, this isn't exactly a new class of drugs either. In fact, the first one of them to be FDA approved was Byetta back in 2005. And just before we dive too far in, I want to, start with a fun fact about Byetta. Its generic is exenatide, which is actually a synthetic version of a peptide that is found in the venom of the Gila monster. Now, for those unfamiliar, a Gila monster is a large lizard that's native to the southwestern U.S. and northwestern Mexico. It sort of resembles like a smaller Komodo dragon.
I remember the Gila monster well, the orange and black.
Yes, absolutely. They're terrifying looking.
Yeah.
Which doesn't help. Might not help our cause here for a moment, but at this point, our listeners might be wondering two things. First, is exenatide harmful? And second, probably more importantly, is, well, how does something like this get used ultimately for diabetes?
Yeah,
well,
I'm curious.
Right. So I should note up front that the Gila monster venom is not fatal to humans. Plus, exendin 4, which is what exenatide, hence the name, was based on. It's just one single peptide out of the many that are found in that venom. So in reality, it's not really responsible for any of the negative effects of the Gila monster's venom. What's also so interesting about this discovery, to answer the second question, is that it was ultimately determined that this peptide, exendin 4, very closely resembled glucagon-like peptide 1 analog, which we'll be referring to as GLP-1 for short. And GLP-1 is a hormone that's released in our digestive tract whenever we eat. And essentially, GLP-1 slows the movement of our stomach and stimulates the release of insulin from the pancreas.
Chris, I
So,
wanted to. Oh, I'm
yeah,
sorry. I wanted to interrupt you real quick. Out of curiosity, do you know if the discovery of the peptide from the Gila monster, was this a casual, hey, would you look at that moment, from scientists who were looking at the Gila monster venom for completely separate purposes? Do you know that?
I actually don't know that. I tried looking a little bit more into what spurred the person to look further into it, but in all honesty, I'm not sure. A lot of times with drug development, they do try to just cast a wide net and kind of check things and see if certain peptides resemble things in the human body just for future drug discovery. So it may have been that they checked it against a drug catalog, or, a chemical catalog, but I'm honestly not 100% sure.
Okay.
Okay. Speaking of, when we speak about GLP-1, the one drawback of our natural GLP-1 is that it only works for a matter of minutes before it gets broken down naturally in the body. So what was revolutionary about the development of Byetta is that scientists were able to find a way to make this peptide effective for much longer than the naturally occurring human GLP-1 peptide. And that's basically why this medication class is so effective for diabetes and obesity. In one way, you're increasing the release of insulin, which is helping to drive down blood glucose levels. But because it only works, in response to food being present in the stomach, it doesn't carry as much of a risk of hypoglycemia or low blood sugar as other diabetes drugs do. Think like insulin, for example. And in another way, you're slowing down the gut, which makes you feel fuller for longer, which in turn leads to you eating less during meals and ultimately results in weight loss. So, let's fast forward to now where we have 6 GLP-1 agonists on the market. The confusing thing is that there are 10 brand names that correspond to these 6 agents. So I hope to take a minute just to clear that up a little bit. So we have the first 4 are actually just approved for diabetes. So we have exenatide under the brand names Byetta and Bydureon, lixisenatide under the brand name Adlixin, dulaglutide under the brand name Trulicity, and tirzepatide under the brand name Mounjaro. I do want to take a quick moment just to kind of highlight Mounjaro. Mounjaro is the newest approved in this class of medications, and it's a bit of a misnomer to lump it in with this class of medications because it's not a true GLP-1 agonist. It's a dual GLP-1/GIP agonist, but suffice it to say it has basically the same type of effect. In fact, it actually works better than than any others in this class that we're seeing from clinical trials. It has better A1C lowering and better weight loss. So it is actually being studied in weight loss and is likely to be approved for weight loss, but yet at this time, it's only approved for diabetes right now. The last 2 are approved for both diabetes and weight loss, and I'll just highlight the fact that they have different brand names based on whether it's the diabetes drug or the weight loss drug. And that's, for many different reasons, but one of the reasons is these 2 medications use higher doses when they're used for weight loss. So the first of these is liraglutide, which when used for diabetes is called Victoza, and when used for weight loss is called Saxenda. And then semaglutide, which is, kind of getting the bulk of the attention throughout our discussion today, when approved for diabetes, is under the brand names Ozempic and Rybelsus, and when used for weight loss under the brand name Wegovy. So just a quick note, all of these products are injectable with the exception of Rybelsus, which is a semaglutide product. It was approved in 2019 as the first oral GLP-1 agonist, which was really a big thing when you think about it, because these are the other ones are injectable, and you have to consider that some individuals have a hard time giving themselves injections. So it was kind of one of the revolutionary approvals in this class.
Chris, with the majority of these drugs being injectables, as you just said, and including the ones with the most media attention, like Ozempic, like Wegovy, does the oral Rybelsus work as well as the injectable counterparts? And that, out of curiosity, because many people hate needles, it sounds like that would be more preferred course, but you're not hearing as much about Rybelsus as the others.
Sure, exactly. So, it would be a preferred option. Unfortunately, it's not been studied head to head against its injectable counterpart. So we've not actually seen oral semaglutide versus injectable semaglutide. But when you look at, an indirect comparison, basically like how did each compare to placebo, unfortunately, you do see slightly less effectiveness with the oral semaglutide compared to the injectable semaglutide. And that kind of makes a little bit of sense. You have one that has to go through the gut and get absorbed, whereas you have the other one, you're injecting straight into the body. Those tend to have a little bit higher absorption throughout the body, so it tends to be a little bit more potent. Now, with that being said, it's not a huge difference. You're getting about 1 kilogram less of weight loss with oral semaglutide than you do with the injectable semaglutide. That's about 2.5 pounds less with the oral semaglutide. So, if you're having a conversation, and you're weighing whether or not a patient would use oral or injectable semaglutide for diabetes, of course, because oral semaglutide or Rybelsus is only approved for diabetes. But if you're having this conversation and a patient is adamantly against using the injections, you're certainly not losing a ton by giving them the oral semaglutide. And speaking anecdotally, I do know a few folks who have used Rybelsus, and the results are pretty striking.
Yeah. Well, keeping in line with that, with people using it, how do providers determine who should take these drugs?
Sure. So obviously, I know that the overarching spirit of today's conversation is probably more on the weight loss side, but I'd be remiss if I didn't mention the fact that when we're using these for diabetes, many of these drugs have proven to reduce the risk of cardiovascular events. Think strokes and heart attacks. Specifically speaking about Trulicity, Victoza, and Ozempic. So for patients with diabetes, these medications are highly recommended for any diabetic patient with either a history of cardiovascular disease or those who may be at risk of developing cardiovascular disease. And of course, they can also be used in any diabetic patient who are simply in need of additional glucose lowering, regardless of their cardiovascular status, because they're really strong A1C or blood glucose lowering agents, of course. Now, regarding the use of pharmacotherapy for weight loss, it's nice because there's basically a blanket criteria from the FDA for all medications that are approved for weight loss. And it basically states that patients qualify for weight loss medications, so in this case, Saxenda and Wegovy, if they have either a BMI of 30 or greater or a BMI of 27 or greater with at least one weight-related comorbidity. So think type 2 diabetes or high cholesterol.
Are there any significant safety concerns present when using these medications? Any standout side effects?
Sure. So, probably the most highly touted, the most common adverse reactions are, of course, the gastrointestinal effects. And this kind of makes sense when you consider that these drugs work by slowing down the activity of the gut. So it's kind of safe to assume that they would have some impact in some sort of way on the gut and the stomach. So patients will commonly experience abdominal pain. They could experience constipation or diarrhea. They could experience nausea and vomiting. Patients may also experience decreased appetite, which, when we're talking of weight loss, is sort of desired in a way. But they also may experience just general stomach upset. So it's important for individuals to know about these effects before they start the medication, because we often recommend that patients take certain steps to help mitigate these effects in advance, such as eating smaller meals and eating more slowly, because remember, you're going to feel fuller a little bit faster, and you're going to feel fuller longer. So you don't want to eat so fast that you kind of become overwhelmed with this sense of fullness and nausea. It's also important for patients to understand, that these effects tend to occur more during the dose escalation phase, because most of these medications do require some sort of dose escalation and titration, and then it will decrease over time. So in many cases, this dose escalation can either be performed more slowly, or we can take steps backward and kind of go back down in order to help patients mitigate these effects as well. Now, there are, of course, other warnings and precautions associated with these medications, such as an increased risk for pancreatitis, as well as an increased risk of thyroid tumors in those patients who are predisposed to those types of things. However, these are somewhat rare occurrences, and they're obviously screened for prior to starting the medications by the ordering providers.
So if you're a patient that is prescribed these medications, you're not struggling with any of the side effects in a significant way, and they're working well for you, do you have to stay on them indefinitely, even if you're adopting a healthier lifestyle to counteract that? But is that something where the medication basically gets you started in that direction, and then you can maintain with good diet and exercise and not be on it? Or is the medication necessary to keep going? I mean, obesity is a chronic condition for a lot of people. So I was curious to how long do you have to stay on it to keep those optimal weight results?
Right. And you really touch on a big area of discussion, because, we shouldn't take for granted the fact that these are very expensive medications. And from an overall healthcare costs perspective, we do have to be conscientious of how much healthcare spend is going on with these medications. So this is a big area of discussion. So I will say, I will start that individuals don't necessarily have to stay on these medications indefinitely. However, it's important that I highlight the fact that, in the clinical trials for Wegovy and for Saxenda, individuals who discontinued the medication, unfortunately, they did regain some of the weight they initially lost, upwards, 50% of the weight that they lost, despite continuing those intensive lifestyle interventions that they were doing in addition to the medication. So these results basically suggest that obesity, basically what you alluded to in your question, is a chronic disease, much like we see with high blood pressure or high cholesterol. And if we think about that, we know that when individuals with high blood pressure, when they stop taking their medications, what happens? Their blood pressure goes back up. So for this reason, many may require long-term treatment with these medications. I will caveat that, though, by saying that if we think along those same lines, there are instances where individuals with chronic metabolic diseases like prediabetes or high blood pressure, some of them are able to eliminate their disease simply through intensive lifestyle modifications. So, for some, they may not need to use these medications long term, so long as they're able to commit to their newfound lifestyle. So I don't think I don't think it's ever going to be as simple and cut and dry as thou shalt stay on forever, or thou shalt be on for initial 3 months to trigger weight loss. Or I guess technically these were studied mostly for 26 to 52 weeks. So it may be difficult to put a blanket statement out there. It's always going to come down to a patient by patient discussion, and how willing and able are they to commit to those changes they've made during their therapy, and if they're going to be able to continue them after getting off the therapy, or if they're just going to need the therapy long term.
Thanks for listening to PodcastRx from Diamond Pharmacy Services. If you're a fan of the show and have any topics you'd like to hear us discuss, or if you have any thoughts on a particular episode you'd like to share, please email us at podcastrx@diamondpharmacy.com. And while you're at it, please rate and review our show wherever you get your podcasts. Your feedback helps us make the best show possible for you. And as always, we appreciate your feedback and support. Now back to the show.
I wanted to ask also, Chris, how these GLP-1 agonists that are approved for weight loss compare to the previous weight loss medications in terms of overall safety and efficacy. I made a reference to fenfenner in the opening there as one that did not stand up with safety concerns over time. But just looking at the available the available record of these types of medications, how do these GLP-1s hold up?
Yeah, and there've actually been a couple medications in this space that have been withdrawn from the market. So it's kind of had a contentious past. Weight loss drugs have always had not just a difficult time in societal uptake and insurance uptake, but also too from the safety perspective, it's they've always had a bit of a mired past. So I do want to caveat first that it's important to note that these various weight loss drugs haven't been directly studied against one another, so you can't make any definitive claims. However, if we judge them from their respective clinical trials, generally speaking, the GLP-1 agonists, and particularly Wegovy, the semaglutide product, they're the safest and most effective treatment options. So just to kind of level set for us, Saxenda trials or liraglutide trials resulted in an average of 8 to 11 pounds more than placebo. And we're going to be referring this in terms of weight loss more than placebo, just so that you get a true effect. Because in these weight loss trials, you usually do see some good placebo effect. So it's important to kind of isolate that. So every bit of weight loss I mention is going to be in terms of more than placebo. So Saxenda was 8 to 11 pounds more than placebo, and Wegovy trials resulted in an average of 22 to 27 pounds more than placebo. So to get a better appreciation of how these compare, we should at least mention the other FDA-approved options on the market. And first, we have the old tried and true, the stimulant medication phentermine, which is available either on its own or in combination with topiramate, which is a seizure medication. Phentermine, either alone or in combination, resulted in a weight loss of around 8 to 19 pounds more than placebo. That higher end of the spectrum is obviously when it's in combination with topiramate, which is pretty good. But obviously, stimulants can have negative cardiovascular effects, typically through increased blood pressure, increased heart rate, and topiramate tends to have negative impacts on cognition. So certainly not benign by any means. Another treatment option is the combination of naltrexone and bupropion, known as Contrave. Now, individuals taking Contrave lose about 9 pounds more than placebo. And it's not necessarily an unsafe option, but of course we know that bupropion is an antidepressant, so it may have some behavioral effects. And we know that it also shouldn't be used in individuals prone to seizures. And what's important to note is that the other ingredient, naltrexone, actually blocks the effects of opioids and alcohol, which can of course be problematic if patients were to require pain management with opioids. And then finally, yeah.
Oh, sorry, Chris. I just wanted to note that I think I don't know if it's your very first appearance on this show or your second, but you talked with my colleague Ashley about medication-assisted treatment, and you were talking about these drugs. And at the time, I just had no idea that there was a weight loss dimension to naltrexone and bupropion. So just a fascinating tie back to one of your previous episodes. Yeah.
And it just goes to show you the versatility of drugs as a whole, but specifically naltrexone. I mean, it seems to be studied in a lot, in a variety of things, and a lot of it comes down to its ability to quell cravings. So that's why it's involved in this medication. But like I said, it can be particularly problematic in certain patients if you were to require these. If you were to require opioid therapy, it can be kind of a little bit difficult.
Right.
So, lesser option or lesser used option is orlistat, which prevents fat absorption, basically prevents your body from getting any fat from the food that you eat. So, while it results in about 7 pounds of weight loss more than placebo, obviously its main drawback is the fact that fat is passing through the stool, which leads to a lot of diarrhea and fatty stools. So obviously tolerability is quite an issue with that medication.
Yeah, I would say so. I mentioned in the opening about Ozempic becoming popular on TikTok and social media, and also reportedly among the celebrity set. So do you think that the recent shortages of Ozempic and Wegovy are primarily the result of this fervor? I mean, it's always easy to scapegoat celebrity culture for these kinds of things, or do more pedestrian factors apply here, say like supply chains or insurability?
So obviously, like TikTok and social media does garner a bit more of the news headlines, but in all reality, it's really a bit of both type situation. Not long after Wegovy, which of course is the weight loss version of Ozempic, was approved, Novo Nordisk, which is the manufacturer of both Wegovy and Ozempic, they started to experience production issues. And this actually led to an initial shortage of Wegovy, which in turn led to some providers prescribing Ozempic, which is albeit off label, to their weight loss patients as sort of a short-term measure. When you add this to the hype that has now been generated by social media, and as well as when you consider supply chain restraints, you can kind of see how this could start to snowball. So I did check, and the manufacturer, Novo Nordisk, they do state that they expect manufacturing to be back to capacity by the end of the year, with product back on the shelves sometime in January 2023. So keep our fingers crossed for that. Now, it should be noted that this shortage really has only impacted predominantly the semaglutide products, Ozempic and Wegovy, and not the liraglutide products, Victoza or Saxenda. This is likely due to the fact that semaglutide is the more potent of the two GLP-1 agonists, a point that was proven in a recent head-to-head clinical trial in which more patients lost more weight with semaglutide than liraglutide. But just a note regarding the landscape as a whole, that's sort of, how it impacts the weight loss management. This shortage, unfortunately, does spill over a little bit more to the diabetes side, though, because of the increased demand on Ozempic. And shortages on Ozempic, we are starting to see small supply chain disruptions of other GLP-1s for diabetes, like Trulicity. So as with any drug shortage, you kind of see when one goes on shortage, the others in the class go on shortage because you see market shifting over to utilize the alternative products. So for right now, liraglutide for weight loss and diabetes remains unaffected, but Trulicity for diabetes has started to kind of take a little bit of a hit. So it's always a moving target, and always, from our perspective in the pharmacy, it makes for very interesting days when you're trying to figure out what to use.
Right. Absolutely. One thing I wanted to follow up on, Chris, is the issue of insurability. I mean, oftentimes these weight loss medications aren't covered. Wegovy, for instance, can be almost $1,000 a month then out of pocket. So what are your thoughts on right now where these drugs sit with insurers?
Yeah, it is. I do believe, and it's hard for me from where I stand, because we don't deal a ton with insurance, not as much as, say, our retail counterparts or those in managed care. But I will say that I think we are starting to see an uptick I should say not uptick, but we're starting to see a bit more uptake from the insurance companies, because obviously it makes sense. It was once said an ounce of prevention is worth a pound of cure, right? So it's always better to kind of treat things up front. And of course, the obesity epidemic is not going away. So it's better often to incorporate these into formularies and at least provide some payment for them so that patients can get these and prevent basically more chronic comorbidities and more costly hospitalizations down the line. Now, with that said, there are still, and there have been for the longest time, some hurdles to jump through, and it may still be that plans require these alternative agents, which we had mentioned before, because they are considerably less expensive, like phentermine or Contrave even. So you may still see plans requiring what they consider step therapy, where you kind of go through the steps of using these lesser effective drugs to see how those work. But I think overall, the arc is bending toward utilization of these drugs. It's just going to be difficult because, like you said, they are very expensive. They're on the orders of $1,000 to $1,500, per month, depending on what product you're looking at.
I wanted to circle back to Ozempic and what you were talking about with prescribing Ozempic off-label for weight loss just because of the shortage of Wegovy. Using drugs off-label, that's nothing new. And of course, there's a widespread desire to lose weight. There's very likely going to be people who are seeking Ozempic in particular that maybe don't really need it, especially if we're talking about celebrities and TikTok influencers. From my reading on this, there's not much data on semaglutide use in people who don't have type 2 diabetes. So is there any concerns do you have as a pharmacist about people using it who perhaps shouldn't?
Right. So, I will say that the drugs, when they're studied for weight loss, they are studied independently of type 2 diabetes. So when we say that things are safe and effective for weight loss, for example, like Wegovy, that included patients without type 2 diabetes. So they're relative, the safety for patients with diabetes or without diabetes would be the same, because they are a very low hypoglycemia risk medication. So that's usually pretty okay. So, my thoughts on this are, so long as an individual is using a GLP-1 agonist under the supervision of a medical provider, whether it be on label, or off label, and they meet the criteria to use a weight loss medication, then I don't see a huge issue with it. Obviously, as I kind of alluded to in your previous question, with the obesity epidemic looming as large as it is, using a tool to promote weight loss can really only be a good thing. Now, that said, I would have concerns if we start to see normal weight individuals, either, celebrities and stuff like that, starting to use these either to lose a quick few pounds or as a way almost prophylactically to allow themselves to eat whatever they want. This scenario I would consider to be a misuse of a very important group of medications. And something that's more of just an interesting thing to note, speaking from a provider perspective, there's been some mention that if a patient is prescribed Ozempic, for example, and the provider is really using it for weight loss, that patient then could possibly be tagged by the insurance company as being a diabetic, because in their system they see Ozempic is used for diabetes. This patient must be diabetic by way of Ozempic, which is really going to throw providers through a loop, because then they're going to be subject to the various quality measures that would apply to a diabetic patient, and make sure they're checking off all the boxes for the care of a diabetic patient when that patient may not necessarily be diabetic. So it's just going to be interesting to see how providers handle that from their perspective as well.
Right. Well, I think at a key point you hit was that these should be taken under the supervision of a medical provider. Some of the articles I read, for instance, and in researching this topic, there were some providers expressing concern that there were people obtaining Ozempic not from their doctor's office, but from places like a health spa. So,
and while I do like to say that GLP-1 agonists, aside from the GI side effects and stuff like that, which is, I'm not, I don't want to, just blow by that, because it can be very considerable for patients. I do say that they're relatively safe. But with that in mind, there is a boxed warning regarding patients who have, regarding a risk of thyroid C-cell tumors. And this is, basically any patient who has a personal or family history of medullary thyroid cancer, or patients with multiple endocrine neoplasia syndrome type 2, which are, obviously glanced over in the commercials for these medications. And obviously these are very rare. But the point being is that's a very real consideration, and that's a very strong contraindication to the use of these medications, and something that if you were to go to, say, a less scrupulous avenue to get the medication, that may be overlooked. And for the one person that's relevant for, that could be a very detrimental scenario to have.
Oh, most definitely. For my last question here, Chris, as always, I like to bring our discussions back to what you do every day with the optics team at Diamond. And your department, of course, addresses a lot of diabetes care concerns in the correctional space in particular. So are you getting a lot of provider questions about the GLP-1 agonist we talked about today? Are you seeing upticks in prescribing trends, for instance? And what else can you tell me in general about how these are being utilized?
Yeah, so we do get a lot of questions, and we are seeing an uptick in prescribing trends. Obviously, mostly, in the diabetes space.
Right.
Ever since these drugs started to show that cardiovascular benefit that I had mentioned before, the diabetes guidelines have been recommending them higher and higher. And anytime you see strong guideline promotion, you obviously start to see larger uptake and uptick in the community. And hence we see more individuals entering the correctional environment already on these medications. So that's something that our correctional providers have had to deal with, the question of whether or not they continue these medications. And, and generally speaking, we tend to recommend that, that they continue these medications. But, additionally, we have also had providers in the correctional space who are starting to realize that these medications provide, a safer alternative to insulin. And I've dealt with some who have even initiated these medications in the correctional environment. Now, with regard to weight loss, we still haven't seen as large of an uptick in corrections as we have in the community. But I'd argue that, given that high price tag that we had mentioned before, that slow uptick is sort of expected. Weight loss medications have always been slowly adopted, as I mentioned before, even in the community setting. So of course, we're going to, see a bit of a slow uptake in the correctional setting as well.
Well, Chris, it will certainly be interesting to watch the development of these medications in the coming years, whether in the community or in the institutional space, how they'll be prescribed, prevalence in both. Chris Bender, pleasure as always to have you on the show. Congratulations once again on becoming a dad. And thank you so much for taking the time to talk with me today.
Well, thank you so much, Adam. Thank you for entertaining the topic. I'm always glad to come on here and talk with you. So I'm looking forward to the next one.
Well, it'll be sooner than you think, I'm sure.
Exactly.
All right. Thanks, Chris.
All right. Hey, take care.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.